All right, welcome to this year's edition of the most commonly missed keyword topics on the ABA's Anesthesiology and Training exam within our residency program here at Robert Wood Johnson. We finally got our results back a few weeks ago, and I've been poring over the list of keywords that they give us from the exam. The list that we get includes all keywords, both those that we did well on and also those that represent gaps in knowledge when we compare ourselves to the rest of the country. The presentation that follows here is part 1 of 2, and only keywords representing our own knowledge gaps are included in this presentation. So please enjoy. So a little bit more about how to use this review. So the ABA compiles a list of every item tested, and then they break it down by the percentage of residents who answered each question correctly. They look at the national average, and they give us the average of residents in our program. And so it's very easy to look at the differences and decide where your own knowledge gaps lie. So a little bit more about this test, which fascinates me every year. 7,400 residents took this exam this year, and that's up several hundred residents from just a few years ago. So there are more and more and more residents in the country every year. The items included in this exam were missed at a rate of at least 7% higher than everybody else in the rest of the country. So these represent true knowledge gaps within our own residency program. All right, so a little bit about the results throughout our program. So the CA1 class had an average scaled score of 33.58. This correlates to the 48th percentile on average. So good news, the CA1s, you're right smack in the middle of the national average for your training year. The CA2s get this nice improvement graph sent by the ABA. It shows that last year's CA1s, you were up right about at the 90th percentile on average. You guys all came back down to earth a little bit this year, settling just over the 50th percentile. So there's a little bit of work to be done, but in general, you're still sitting in a pretty good position here. The CA3s, we showed you this graph a lot last year when you were CA2s. You were way up off the charts, way above the 90th percentile, still doing pretty well, right around the 75th percentile, but the advanced exam is coming up, and now's not the time to slack. So please take this into account, learn something from it, and make us all proud on the advanced. All right, here's how this presentation is set up. So I've broken down the topics into the 5 different categories that the ABA recognizes. They are the basic sciences, clinical sciences, organ-based sciences, clinical subspecialties, and special issues in anesthesiology. For the CA1s, just because you're preparing for the basic sciences exam, doesn't mean that the other categories are irrelevant to you. There are basic science questions that fall within these other subcategories as well, but you'll see these images below on the throughout the presentation based on what type of question it is. In the upper right-hand corner, you'll also see the percentage of Robert Wood Johnson residents that got the question correct versus the national percentage of a correct answer. And you'll notice that each of the items Robert Wood Johnson residents answered correctly at least 7% less than the national average. So what should I do? Watch and review this presentation. I hope that you learned something from it. I'm sure every single one of you has answered a question incorrectly that's covered here. Take these keywords back and use your favorite resource to go over some of the learning points from each keyword, and use your own individual report. So every resident gets a report very much like the one that I used to make this presentation that was a collective report, but everybody has the ability to see the keywords that you missed as an individual. So please use the resources that the ABA gives you. They want you to pass these tests, they really do, but you definitely have to put in the effort to do so. Okay, so that is enough preamble. Our first keyword that we need to review here, we got 38%, whereas the US average was over 50%, is L-spine radiologic anatomy. So as you can see here, this is an image representing a lumbar vertebral body. Some of the key components in this picture are both the superior and inferior articular processes. These make up the facet joints. The transverse process, the spinous process, the pedicle, and then the vertebral body. Now, the next image here is what this looks like on X-ray. This is an oblique view of the spine. The eye of the Scotty dog there that we hear so much about when we're rotating with Dr. Grubb represents the pedicle, and then the pedicle gives way to the superior articular process making up the facet joint with the inferior articular process of the vertebral body, the vertebrae rather, above it. The snout of the Scotty dog represents the transverse process. The back leg represents the spinous process, and the front leg represents the inferior articular process of the vertebra above. Our next keyword here is MAC age effects. So as we should remember, 1 MAC of inhalational agent represents the concentration of the agent where 50% of the population does not move to a surgical stimulus. Now, when we think about MAC in terms of age, from birth until about 6 months of age, MAC increases significantly by about 30%, and between 6 and 12 months, it is at its highest. It remains relatively high throughout childhood, and then as childhood goes on, each decade sees about a 6 to 7% decrease in MAC all throughout life. Okay, our next keyword here is pH and log scale of pH. So the pH scale is used as an assessment of acidity for everything on Earth. Because acidity, or the concentration of hydrogen ion, varies wildly based on application, a scale had to be created in a nonlinear fashion. The best way to accomplish this is through a logarithmic scale. This means that for an increase or decrease in one integer value, the concentration of hydrogen ion changes by a factor of 10. Physiologically, we operate in a very narrow window of hydrogen ion concentration that is compatible with life. So for instance, if the pH falls from 7.4 down to 7.1, which unfortunately we see sometimes taking care of very sick patients, the hydrogen ion in the body doubles. If we were to somehow move from a pH of 8, which is not necessarily compatible with life, down to a pH of 7, that would represent a 10-fold increase in acidity. 8 to 6 would represent a 100 times change in hydrogen ion concentration. 8 to 5 would represent a 1,000 times change, and so on. More and more, the board is testing topics in ultrasound as well as echocardiography. So this keyword is TTE and RV function assessment. So around the country, especially in the community, the most common way of assessing RV function is just eyeballing the RV and assessing how well it moves based on the echocardiographer's experience. There are several other more academic ways to measure RV function. The two most common ways are known as TAPSE and S', and we'll talk about those here and leave some of the others for a different discussion. So the first TAPSE stands for tricuspid annular plane systolic excursion. What this means is that the echocardiographer gets a 4-chamber view and directs the M-mode beam through the lateral tricuspid annulus, and during systole, the M mode is used to see how far the lateral tricuspid annulus moves toward the apex, and that is reported in centimeters, and that's the TAPSE reading. S' uses tissue Doppler to look at very much the same thing. It looks at the lateral tricuspid annulus and looks at the velocity of the lateral tricuspid annulus during systole. Okay, our next keyword moves into the endocrine system. It is adrenal insufficiency and the treatment for adrenal insufficiency. So in general, there are three main categories, named primary, secondary, and tertiary in a very creative manner. And the diagnosis and treatment varies between the three different types. So primary adrenal insufficiency is also known as Addison's disease. And this occurs when the adrenal cortex does not produce sufficient levels of glucocorticoid despite appropriate levels of adrenocorticotropic hormone, or ACTH. Secondary adrenal insufficiency is caused by a lack of stimulation of the adrenal cortex due to insufficient levels of ACTH. And finally, tertiary adrenal insufficiency is caused by the suppression of the HPA axis, which is pictured over to the right, by exogenous glucocorticoid exposure. So the treatments vary based on type, but they all include glucocorticoid supplementation, which is generally hydrocortisone plus or minus a taper. Treatment also surrounds electrolyte and fluid management. So in adrenal insufficiency, we often see hyperkalemia, hyponatremia, and hypoglycemia. And so those electrolyte imbalances need to be managed very closely. Okay, our next keyword is ASA sedation standards. So the ASA takes sedation by both anesthesiologists and non-anesthesiologists very seriously, and they have put out a series of recommendations for folks who give sedation who are not trained as anesthesiologists, and so we'll review some of these here. So in general, sedation is a continuum. Practitioners who provide sedation in general should be able to rescue patients if a deeper level of sedation than is originally intended does occur. They break the various levels of sedation into four main groups. So minimal sedation represents anxiolysis, where patients still are awake, but they are relaxed by medicines that were given. Moderate sedation means that patients still have purposeful movements in response to voice. Deep sedation means that patients will still have a purposeful response either to pain or a repeated stimulation. And then general anesthesia implies that patients are unarousable. So the ASA puts out several recommendations based on the practitioners and based on the depth of anesthesia. So they say, make a couple of strong statements. They say that all patients getting sedation must follow NPO guidelines. We won't go into the exact NPO guidelines here, but they must follow the ASA's NPO guidelines. With monitoring at a minimum before the procedure begins, after sedation is given, at regular intervals throughout the procedure, during initial recovery, and then before discharge, patients should have their level of consciousness, their ventilation, their oxygenation, and their hemodynamics closely monitored. The ASA also makes comments about training that providers should have. They must, at a minimum, be familiar with the pharmacology of the agents that they're using. They must have the ability to rescue, as I said earlier, patients one level deeper than intended, meaning that if patients should suddenly go from a moderate sedation to a deep sedation, where they may have some respiratory or airway compromise, the practitioner should be able to rescue them from that respiratory compromise. There also should be somebody who has ACLS skills within 5 minutes if somebody is undergoing moderate sedation, or in the room if a patient is undergoing deep sedation. They also make additional comments about titration of substances and how that should be done, how to provide supplemental oxygen, how to obtain and keep IV access, and also what recovery care after sedation should look like. And this, of course, is regardless of who is providing sedation, anesthesiologist or otherwise. Here we have gastric pH and medication effects on gastric pH. So there are several medications often used to try and increase gastric pH in patients who are at high risk of pulmonary aspiration. The ASA recommends targeted use of these medications rather than widespread use for everyone because of various side effects of these medications. We care about gastric pH because if an aspiration event does occur, the more acidic solution increases a patient's risk of aspiration pneumonitis, which is an inflammatory reaction within the entire respiratory system. 3 of the most commonly used medications are H2 blockers, proton pump inhibitors, and non-particulate antacids. H2 blockers will increase gastric pH and reduce volume, but they must be given 1 to 2 hours prior to surgery to have a full effect. PPIs will increase gastric pH for 24 hours when patients are consistently taking the medication, and if used in combination with an H2 blocker, they may further increase the gastric pH as well. Non-particulate antacids are used in the short term to increase gastric pH, and those are especially recommended to be used in a targeted way just because it does slightly increase the volume of what's in the stomach. Other medications that are often used to increase gastric motility and decrease gastric volume, such as metoclopramide and anticholinergics, do not necessarily have an effect on pH. So for some reason, especially on the basic exam, the ABA loves to test hyperbaric oxygen. And so on the in-training exam this year, they tested the indications for this treatment. So what hyperbaric oxygen therapy does is it increases dissolved oxygen in blood using Henry's law. Now what Henry's law is that the proportion of gas dissolved in a solution is directly proportional to its partial pressure. So by increasing the partial pressure of oxygen, you have more oxygen dissolved in the blood. Now indications are loosely broken into 3 categories. They are wound healing and angiogenesis, antimicrobial effects, and then emergencies. And there are different things within each subheading that can be an indication. So in wound healing, this works by generating reactive oxygen species that help wounds chronically. They can be burns, trauma. Diabetic patients will often have hyperbaric oxygen therapy for non-healing ulcers and such. Antimicrobial effects, so oxygen can have an effect on certain microbes, including Clostridium. Patients who have Fournier's gangrene or necrotizing fasciitis may respond to hyperbaric oxygen therapy. And some emergencies can also be treated by hyperbaric therapy as well, including air embolism, where hyperbaric therapy will help to shrink the embolus, and various poisoning, either carbon monoxide or cyanide. Central retinal artery occlusion can be treated as well, and sometimes crush injuries can respond to hyperbaric therapy. There are some contraindications along with indications. So pacemakers, pregnancy, epilepsy is a contraindication because patients are at slightly higher risk for seizures during this therapy. And then patients on bleomycin therapy are also not supposed to have hyperbaric oxygen therapy just because the risk of oxygen toxicity increases. The next keyword here is hypothermia and coagulation effects of hypothermia. So when patients become cold, coagulation suffers. The mechanism for this occurs mainly in 2 ways. So the first is that, especially seen with profound hypothermia, platelet aggregation is reduced. Now, some studies have shown that with mild hypothermia, the effect on platelets is not as profound, or the platelet activity may actually be increased. But the second mechanism is that activity of coagulation enzymes involved in the coagulation cascade is reduced as well. This would lead to a TEG that looks like this, where thrombus formation takes longer to occur initially. Now, hypothermia is not the sole variable in coagulopathy, however. So in trauma care, we often worry about the triad of death, which is imaged over here on the right. That includes acidosis, hypothermia, and coagulopathy. Now, acidosis also has a profound effect on coagulation, and this can be a confounding variable when we're talking about the relationship directly between hypothermia and coagulopathy. So again, this year we have last treatment on our list of keywords where we did a bit worse than the rest of the country. We go over this just about every year, but it's always a good thing to review again. So last, or local anesthetic systemic toxicity, has an overall incidence that's reported as about 1 to 2 patients per 1,000. And that's using 2 recent studies, though over time the overall rate has decreased significantly with increased ultrasound use and better expertise with some of our fellowship-trained folks. However, all things considered, this is still a relatively common complication that we should know something about and should always be at the forefront of our minds. So the classic presentation includes symptoms of CNS excitation. This can include perioral numbness, a relative metallic taste in the mouth, tinnitus, agitation, tremors, and then ultimately these symptoms can lead to seizures if appropriate intervention doesn't take place. These CNS symptoms can unfortunately progress to cardiovascular depression in the form of arrhythmias, conduction delay, and ultimately asystole if the progression is allowed to go that far. Now, a high proportion also will present atypically, meaning that cardiovascular depression will either come first or central nervous system and cardiovascular symptoms will occur simultaneously. Not every patient is at the same risk for last, so increased risk comes with extremes of age, pregnancy, as pregnant patients are more sensitive to local anesthetics, female sex, folks who have a significant cardiovascular disease, and also low protein binding states such as liver disease and other systemic illness. There are also different pharmacologic factors which put patients at higher risk of last. So if we are using an agent that has a narrower central nervous system to cardiovascular system toxicity ratio, patients are at higher risk of having adverse outcomes with last. Total dose, of course, is a pharmacologic factor, and then block site is a factor as well. So the more highly vascular areas tend to absorb the medication more readily, and you all can use your favorite mnemonic to remember the order of sites and systemic absorption for locals. Prevention, so there are different ways that we can prevent last from occurring. Some of the most commonly described ones are slow injection, aspiration intermittently throughout the injection. Ultrasound has been shown to reduce risk by at least 65%. The use of intravascular markers such as epinephrine has been shown to reduce last. Awareness of the additive nature of local toxicity. So if we use, if a patient gets a block with bupivacaine and then we take them to the OR and inject lidocaine IV, that can put patients at higher risk of last. And all patients are not the same. We have to realize that some come in different states of malnourishment, low muscle mass, and children are more tend to be more prone if, for instance, they are having blocks under general anesthesia. So if last does occur, there are some components to treatment that are slightly different than other resuscitative measures that we usually take. So early airway management is very important. The reason for this is that hypoxia, hypercapnia, and acidosis can worsen local anesthetic systemic toxicity based on how the medications can cross lipid membranes. So it's very important to control those three items. After airway management, early infusion of lipid emulsion is very important. So this can be either given in bolus form, and the recommendations are 1.5 milliliters per kilogram bolus. And after that initial bolus is given, further boluses can be repeated, or a slower infusion can be started, and the recommendation for that is 0.25 milliliters per kilogram per minute. If the patient is experiencing seizures, these should preferentially be treated with benzodiazepines rather than the temptation to use propofol, which is a cardiovascular depressant. If cardiovascular resuscitation becomes necessary, there are some things to remember that's outlined in the chart on the right. So it is necessary to use reduced doses of epinephrine if the standard 1 milligram boluses of epinephrine per usual ACLS protocols are used. Sometimes this can cause arrhythmias as the heart becomes sensitized to arrhythmias. There are some medications that we should avoid, including more local anesthetics, which oftentimes will treat arrhythmias with locals. Of course, we shouldn't use more of what is causing the problem in the first place. We should also avoid beta blockers, calcium channel blockers, and vasopressin. If a patient does have cardiovascular collapse, resuscitation should continue for perhaps longer than folks may generally continue resuscitative measures. It's been shown that patients have good neurologic outcomes if ACLS is carried out in a reasonable and efficient way. And if you're at an institution where ECMO is available, the folks who can put patients on ECMO should be notified almost immediately when LAST is diagnosed. Our next keyword here covers the respiratory effects of neuraxial anesthesia. So neuraxial impairs respiratory muscle function in a level-dependent fashion, and this generally only occurs when it spreads to the higher thoracic levels. So in terms of respiratory parameters, peak expiratory flow may be reduced due to abdominal and intercostal muscle weakness, and again, this only occurs really with spread to the higher dermatome levels. We also have some of the other respiratory parameters such as FEV1, FVC, and vital capacity, which may be affected to some extent, but generally significantly less so than peak expiratory flow. Usually these are not affected too dramatically unless neuraxial spreads to very high levels. So patients can experience subjective shortness of breath, and this is a fairly common occurrence, and this is when there's proprioceptive blockade of the abdomen and chest walls. So when patients don't feel their abdomen and chest moving with breath, this can sometimes cause them to feel like they're short of breath, even though their respiratory parameters haven't changed too much. If the block height does spread to the cervical dermatomes, so specifically C3 to C5, this will block the phrenic nerve and ultimately could paralyze the diaphragm. Neuraxial opioids may also lead to respiratory depression. There's some extent of, depending on the type of neuraxial opioid, there may be varying levels of systemic absorption, which could lead to respiratory depression. Moving on, we have spinal anesthesia and the age effects related to spinal anesthesia. So due to different age-related changes in CSF levels, anatomic spine changes, and increased sensitivity to local anesthetics, sometimes spinal anesthesia can spread further and result in increased hypotension than when compared to younger folks having spinal anesthesia. Spinals are often seen as beneficial in the elderly population due to reduced atelectasis, avoidance of mechanical ventilation, less tachycardia, and sometimes less hypotension if dosed appropriately, improved peripheral blood flow, and increased pain control in the immediate postoperative period. Large studies recently have shown no benefit in overall mortality or delirium in certain subgroups of elderly patients when compared to general anesthesia. But of course, each patient is different, and a variety of factors should be taken into account when deciding upon an anesthetic technique. Our next keyword topic is surgical site infection, and specifically prophylaxis for surgical site infection. So a little overview, first of all. Surgical site infections are one of the most feared perioperative complications because they can dramatically increase morbidity and mortality. They can increase length of stay in the hospital, and ultimately they're extremely costly to both patients and the healthcare system. So it's estimated that surgical site infections affect 2 to 5% of all patients undergoing surgery within 30 days of having surgery or within 90 days of obtaining an implantable device. Now, there are different types of bacteria that will cause surgical site infections. The most common are the escape type. Those include Enterococcus, Staph aureus, specifically MRSA, Klebsiella, Acinetobacter, Pseudomonas, and Enterobacter. Now, prophylaxis for these agents includes not just antibiotic prophylaxis, which is probably what you're thinking, though this is commonly done. So antibiotic prophylaxis should be given within 60 minutes of surgical site or surgical incision, rather, to allow for circulation throughout the body. The most common agent that we often all use is cefazolin, and this has good coverage for strep, staph, that is methicillin sensitive, and numerous gram-negative bacteria. Vancomycin and clindamycin are often used for folks at higher risk for MRSA infection, and we have to pay special attention to redosing. So if the time for the surgery is greater than 2 half-lives of the antibiotic that we're administering, it should be redosed. And also, if the surgery entails significant blood loss, we should redose antibiotic at the time of the significant blood loss. It's also important that we minimize post-op antibiotics to try and reduce the amount of resistance that's created. And also, prophylaxis includes other additional non-pharmacologic approaches. So decolonization is important. Patients are often swabbed with special nasal swabs before they come into the hospital to try and decolonize from MRSA. Hand hygiene is as important as ever. We talk about that quite a bit here at our institution. Cleaning the environment is extremely important. So our EVS folks do more than just mop up the things on the floor. They're an integral part of preventing surgical site infection, and then vascular care as well. So lots of different things go into preventing surgical site infections, and antibiotic is just one of them. Our next keyword topic is medication administration routes during ACLS. So it's now understood that the preferred route of access for medications is a peripheral IV. The reason for this is that peripheral IVs are easily placed. When comparing a peripheral IV to a central line, there's no need to interrupt resuscitation and no need to introduce additional complication risk when placing a central line. And medications will, eventually reach the central circulation when given through a peripheral IV as well. If a patient does not have a peripheral IV, the next best choice is an intraosseous line. This tends to be a safe alternative, and the benefit here is that it is able to be placed very quickly, usually either at the tibial plateau or at the humeral head. This offers predictable absorption of fluids and medications, and avoids the time that it takes to place a central line. A third route of administration through endotracheal administration is generally no longer preferred because there is often unpredictable absorption of medications, and this leads to inconsistent recommendations for dosing of resuscitative medicines. Our next keyword topic here is a basic exam topic at its finest, alveolar cell function. Only 46% of our residents answered the question involving this keyword correctly, so it's worth a review. So there are two types of alveolar cells, aptly named type 1 and type 2. So type 1 make up the vast majority of the lung parenchyma, about 97% of the alveolar surface. They are thin squamous cells, and the cytoplasm within these cells is only between 0.05 and 0.2 microns thick, incredibly thin. And the importance of this setup is that it allows for gas exchange very easily without leakage of proteins across those membranes. Now, type 2 alveolar cells are cuboidal cells that are usually found in groups of 2 or 3 throughout the alveoli. They are understood to be progenitor cells that ultimately will give rise to type 1 cells, but the most important function of these cells is that they produce surfactant. Now, surfactant is important because it decreases surface tension throughout alveoli, which ultimately prevents collapse. And surface tension follows the law of Laplace, which says that the pressure within an alveolus is 2 times the surface tension over the radius of the alveolus. Now, this is key because if a larger alveolus would mean that there would tend to be lower pressure within the alveolus, and so air would preferentially fill the already large alveoli. The surfactant is able to reduce the surface tension, which ultimately will reduce the pressure within alveoli, so there's more equal uniform filling of alveoli across all sizes. So surfactant is incredibly important to the overall physiology of the alveoli and the lung. Here we have amide locals and metabolism of these drugs. So amide locals are metabolized exclusively by the P450 system in the liver. Metabolism of these compounds is very efficient, and therefore the rate-limiting step of metabolism is hepatic perfusion rather than liver enzyme function. So therefore, when reductions in metabolism do occur, it's usually due to low cardiac output states where hepatic perfusion is affected. The kidney is involved in excreting amide local anesthetic metabolites. Therefore, renal dysfunction does not necessarily result in increases in active drug, but rather in accumulation of inactive metabolites. So a word on allergies to amide locals. It's extremely rare for a patient to have a true allergy to amide anesthetics. When one is reported, it is often due to additives to the local, such as methylparaben, which is a stabilizing agent, or to epinephrine that was added as a vasoconstrictor to the medication. So our next keyword topic here is anticoagulants and neuraxial anesthesia. The ABA didn't do a great job breaking down this keyword. This is an absolutely massive, complex topic with a lot to remember. Different drugs have different half-times and different safety profiles when in regard to performing Neuraxial. Nicora and Azra are really great resources to stay up to date, especially with newer and less commonly used agents. But in general, not a week goes by that I don't have a conversation with a colleague related to this topic because it comes up all the time, almost every day. So here I broke down our anticoagulants into 3 main groups: antiplatelet agents, oral anticoagulants, and heparin, although many others exist, and this is by no means an exhaustive review of the topic. When looking at antiplatelet medicines, it's generally safe for patients to continue aspirin and to perform neuraxial anesthesia on patients who are on aspirin. Clopidogrel and ticagrelor should both be held for 5 to 7 days, and prasugrel should be held for 7 to 10 days. Now, this is so because it takes approximately 5 to 7 days to adequately replace the platelet pool because these compounds irreversibly bind platelets. About 10 to 15% of total platelet volume is replaced each day, and those platelets become active and can be used again. So anyway, 5 to 7 days for Plavix and ticagrelor. Oral anticoagulants, so warfarin is still commonly tested, even though not as many patients these days are on this agent. Patients should have an INR of less than 1.4 and ideally be off of the medicine for 5 days, although an INR of less than 1.4 is appropriate to place neuraxial anesthesia. Both Eliquis and Xarelto should be held for 72 hours. When looking at heparin, heparin administration is broken down in several ways, both with IV heparin, which I won't necessarily go into here, but sub-Q heparin and Lovenox as well. So with sub-Q low-dose prophylaxis, it should be held 4 to 6 hours or have a normal PTT. It's okay to restart that medicine immediately after placement of Neuraxial, which is a change from just a few years ago when they asked us to hold off for an hour. So now we're able to restart this medicine immediately after a block. With sub-Q heparin and high-dose prophylaxis, it's necessary to hold for 12 hours before a block and draw a PTT to make sure that this is back to normal. Sub-Q therapeutic heparin should be held for 24 hours, although that is a less commonly used medication. So with Lovenox, prophylactic Lovenox should be held for 12 hours and restarted not sooner than 12 hours after a neuraxial block, and therapeutic Lovenox should be held for 24 hours before a block can be restarted not sooner than 24 hours afterward. One last word on the topic. I think that it's very important to either download the app put out by ASRA and use it frequently, or to find a chart like the one seen on the right and spend a lot of time with it. Before exams, it's important to memorize these, but in daily practice, before performing a neuraxial block on a patient who's anticoagulated, please double check your references and don't rely on your memory, because the complications can really be disastrous if we don't pay special attention to this. Okay, this is our last keyword I will leave you with for part 1. It is arginine vasopressin secretion. So arginine vasopressin, or ADH, antidiuretic hormone, is synthesized in the hypothalamus and secreted from the posterior pituitary. Its main function is to increase water reabsorption in the kidney for the purpose of maintaining appropriate tonicity. The strongest impulse for secretion is hypovolemia. This is sensed by baroreceptors in the left atrium, in the carotid artery, and in the aortic arch. These impulses then are delivered to the hypothalamus via the vagus nerve, which then increases antidiuretic hormone secretion. The second strongest impulse for secretion is elevation in blood osmolarity. When ADH is secreted, it then stimulates the kidney to absorb free water. Since volume is a stronger impulse for secretion than blood osmolarity, in instances of hypervolemic hyperosmotic states, ADH secretion will be inhibited. All right, this is the end of part 1. You can go ahead and move on to part 2. If you put in effort preparing for the boards, after you take the test, I'm sure you'll feel just as happy as Rory McIlroy did last weekend. I hope you enjoyed. Take care.